My name is Zach Jenkins, and I'm an associate professor of pharmacy practice at Cedarville University School of Pharmacy. And I'd like to take the opportunity to welcome you to the COVID-19 Town Hall. So you're watching a live town hall that's actually presented by Cedarville University on topics related to the coronavirus. So we're trying to do a series of these that we'll be moving forward within the coming weeks. So this 11-week series is actually going to be exploring everything from the latest updates and progress on the coronavirus to how to manage anxiety and fears during the crisis, how students can adapt and succeed with online learning, how job seekers can adapt and find work, and then lastly, we're going to be covering more topics even beyond that. So each town hall will be live streamed on Facebook Live and the COVID-19 updates blog. This week, both myself and my colleague, Dr. David Peters, will be offering some thoughts on really what we're doing to flatten the curve, as well as what we're doing to raise the bar. And I'll kind of go into a little bit about what that term means here in a little bit. We look forward to answering your questions after the presentation. So with that, let's go ahead and get started. So if you had the opportunity to see my previous discussion on COVID-19 that was posted a little bit earlier this week, some of the information I'll be sharing with you may be a little bit old, but I'm going to give you some new context in some cases with that. But I want to try to get everyone on the same playing field if you didn't have that opportunity to see that previous discussion. A little bit before today's talk, what I ended up doing is I went to the Johns Hopkins Coronavirus Resource Center, and I actually got an image of the most recent data from their center. So at this point in time, we're looking at over 400,000 cases worldwide, with a little bit over 20,000 deaths and about 113,000 or so recoveries. So the majority of our cases are still new. Most of our patients have not necessarily recovered from the coronavirus. If you've been looking at this website at all, one major change that's occurred recently is in the United States, you see all these little dots across this map. These actually represent data down to the county level in a lot of cases. So what's unique about this data in the United States compared to what's being reported throughout the rest of the world through this center is we have now got it down to individual localities. So when you see all of these blips on the radar, so to speak, don't necessarily let it concern you more than other locations. Just know we're doing a lot of testing. To that end, as far as the United States goes, as of 2/10 today, we had over 61,000 cases, 838 deaths, and about 337 recoveries. So the majority of cases in the United States are still new, and we aren't necessarily having a lot of resolution of those cases yet. And this is because the COVID-19 pandemic is actually still in its infancy within the United States. So what that means is we're still on this very steep climb when it comes to the curve. So we're going to be seeing this continue to increase. And just as a reminder, a big reason why is we have improved testing access and speed. And this is continuing to change, especially as third parties are entering the scene. The other thing that happens is we can kind of semi-predict the growth of the virus itself based on the available data. So you kind of expect this linear increase in that growth. I say it's semi-predictable. And the reason I say semi is because we don't necessarily have all the data yet. And then the other reason is there are things that happen that we can't anticipate, like people going from one location to another in a great quantity and those types of things. As we've kind of talked about before, one big concern with the coronavirus is that to date, it's been reported as being more fatal than influenza is on average when we think about most influenza seasons. The current average right now is somewhere about 2.3% of cases. And it does vary, of course, with age and with people that do have underlying medical conditions. What I want to really lay out today, though, is that we know mortality rates are likely going to decrease as the number of known cases continue to increase. So essentially, our denominator, that number of total cases, is actually continuing to increase as we test more and more and more and more. And for that reason, not all of our patients are going to actually have those deaths that do occur. So we should see that number decrease. And over time, we'll get a more accurate idea of what this does look like. With that said, we do still think that the mortality rates are going to be overall higher than the flu. But one thing I've noticed a lot as I've looked at things online, a lot of people focus on mortality as being the biggest issue associated with the coronavirus, when in reality, it's not necessarily that's our largest concern. So we've all at this point, most of us have heard the term flattening the curve. And what I have for you on this image here, or the slide here, this is actually data out of a report by the Imperial College of London. And what they did is they tried to look at different models of growth compared to comparing whether there was whether there were no interventions that were done to when we actually implemented interventions like closing schools, like quarantining people, etc. And looking strictly at the United States, which is represented here, you can see that we have that big curve represented in black when we have done nothing. So that's the peak that we talk about. That's the curve, the worst case scenario we want to avoid. And for that reason, we've been doing a lot of this social distancing. And the idea is we want to avoid rationing healthcare. So if you look at the bottom image on this slide, what you'll see is that there's this area that goes above that red line. And that red line actually represents our surge number of critical care beds. That means extra critical care beds that we have. So in this example, when we have that peak occur above the line, it means we don't have healthcare resources to necessarily deal with that sudden influx of patients. And what this means is we'd have to make real tough decisions about how we're going to adequately ration healthcare. And that's what we've been seeing a lot in other places in the world, Italy being a prime example. Now, one question I did get on this slide that I kind of want to address right now is if you look, you'll see that there are curves that kind of occur later in the year. So why is that? Well, these models you see here assume no pharmacologic interventions. So that means we don't have any vaccinations in these cases or any real cures for the virus itself. So as we delay the spread and growth, we decrease that rate of infection. Eventually, it will peak at some point. So this just assumes that we don't have things like the summer, and again, those pharmacological interventions that would occur. As we see things play out, we know that we're working actively to develop things like vaccines. We're working actively to develop cures, and we're also hoping in a best case scenario that the summer and the seasons will actually impact our growth here. So when we stack ourselves up to the rest of the world, we see that the United States is on a pretty steep incline. Now, part of the reason is we have many focal centers of infection in the United States compared to what some other countries have seen. Another thing is that we're very vigilant. We're looking for these cases actively, and so we have a large number that are being reported. But the big concern has been when we talk about ourselves in relation to Italy. And in Italy right now, they're in that phase where they're really rationing healthcare. So their providers are working long hours. They're getting sick because they're constantly exposed to patients with inadequate resources to treat them. And they're really seeing large instances of mortality, their overall fatalities occurring from this increase. And so the concern is, could that be what happens in the United States? Now, to be fair, comparing Italy to the United States is sort of an apples to orange situation. Because really there are some differences in our populations. There are differences in some of our hygiene practices, how we already may be practicing some social distancing, et cetera. But again, resources are limited. And as I've shown you in that previous slide, we know eventually we may get above that line. Now, how do we stack up in relation to China and South Korea? So unfortunately, in the United States, by the time we were able to implement measures, our testing availability was limited, and they weren't very successful with some of those tests. So we know that potentially in those cases, we actually had some contaminations in the test. There were greater failures with the test. So we weren't really able to contain the virus early on. In contrast, when you look at China and South Korea, that's something they worked very hard at. And a lot of the initiatives they implemented related to distancing were done very hard and very early. So we're on a little bit of a different paradigm when you compare ourselves to those countries. So again, our focus is flattening the curve. And what we mean by that is really delaying how rapidly we see that infection spread. So this actually gives our healthcare system more time, and that's represented here by that blue line. That's the capacity of our healthcare system. It gives us more time to try to deal with these cases so the system itself is not overwhelmed. So as a practical example, right now we know there are about 924,000 staffed hospital beds within the United States. And if we take that number and multiply it by the total days in a calendar year, and in this case, it's 366 days in a leap year, we know that that translates to about 338 million hospital bed days, which is a quantity that we would have in a given year of hospital beds that would be available for this particular year. If we look at what happened in 2019, there were about 36 million hospital admissions with an average length of stay of 4.5 days. And if we use that same kind of approach to this model here, that means that were roughly 164 million hospital bed days that were ultimately used. So that meant that there were roughly 174 million hospital beds left from our total capacity in the year that we had left to spare. So when we look at that in relation to COVID-19, the data to date suggests that about 40 to 70% of the United States may become infected by the time that the coronavirus has passed. So if we take that number and we look at our total population in the United States, which is about 327 million, if we look at the best case scenario, which would be 40%, that translates to 130.8 million people that would be infected. We know based on the data that's available globally that about 15 to 20% of cases will require hospitalization. So again, assuming a best case scenario, which would be about 15%, that would mean 19.62 million people could be hospitalized in a best case scenario in a given year in the United States. We also know the average hospital stay for COVID-19 outside the United States ranges anywhere from about 10 to 20 days. So again, if we assume that best case scenario and go with 10 days here, this means we would need approximately 196 million hospital bed days to adequately manage these COVID-19 patients. So how does that stack up? If we take 196 million bed days that we know we need for COVID-19 patients, and we look at the amount that was available last year overall in the system, we end up with about a 12.6% increase of capacity in our overall hospital beds that we would need to adequately treat these patients over a given year. So that's best case scenario. Or about 67% in a worst case scenario. So this again is just looking at hospital beds, but you can extract a lot of the same logic when we talk about other healthcare resources like medications, like ICU beds as a smaller example, et cetera. So what we're doing to prevent this is, again, flattening the curve. And there are a lot of initiatives that have been kind of taken on by various places within the country and throughout the world, some of which actually take more liberty away and some take less liberty away. So things that preserve liberty a little bit more are things like closing schools, isolating individual cases. And so these are less invasive in the grand scheme of things, but things that end up really becoming, I guess, more politically hot would be things like regulating curfews, greatly restricting borders, restricting travel. And if we look at South Korea and China as examples, you know, you've had facial recognition technology, drones, and involuntary use of GPS on mobile devices to try to contain people and prevent them from further spreading the virus. And then ultimately, even things like true lockdowns where people really can't come out of their living quarters. So these have been implemented in various capacities throughout the world. And even in the United States, you've seen this done differently depending on what state that you're in. So how has this looked in the United States? Now, this is just one example. This is actually a organization that ended up taking GPS data that was publicly available from phones. So there's no real invasion of privacy here. So it's publicly available GPS data. And they looked at seeing how far people traveled based on the locality. And so to date, looking at all the initiatives we've done in the United States, we've decreased our travel, our mobility about 40% from where we were at our baseline. So we have greatly decreased things. And so they kind of assign grades to different states based on how much of a decrease that we saw. So, you know, in Ohio as an example, we've decreased over 40%. So they ended up giving Ohio an A. But there's some caveats you kind of have to take into account when you look at this. This doesn't tell you whether people are congregating in big groups. It doesn't tell you if they're doing things like disinfecting their household. It also doesn't tell you anything about the locality. So an example would be Wyoming, where we know things are spaced far apart. So therefore, people may have to travel more to get some of the resources they need to subsist. So we are doing these things to flatten the curve. But the other thing that we're trying to do is raise the bar. And so if we can move this capacity of our healthcare system at all, it makes it much, much easier to deal with an influx of COVID-19 patients. What I want to explain though is this is actually very hard to do. In contrast, it's much, much easier to try to decrease the rate of the infection because that isn't as limited in terms of resources. But make no mistake, we're doing both of these things at the same time. So from a governmental perspective, in the United States, the president ended up deploying the strategic national stockpile. And so this image you see on this slide represents a large stockpile of medical resources and infrastructure resources we have to help in the event of a disaster. So at the behest of the president, this has been deployed. So things like medications, like ventilators, I think there are about 12,000 ventilators, um, et cetera, have really been started to be pushed out to states that are in need. New York is a great example of that, where we have the largest number of cases in the United States. On top of this, we have regulations being either put in place or relaxed to make things a little bit easier. So one example is we've had a major issue with drug shortages, especially some of these theoretical treatments for COVID-19. We've had people hoarding those drugs, which has made it hard for other individuals who actually may need those drugs for other conditions to get those medications. So in response to this, we've had state boards of pharmacy and other regulations put in place to try to limit how often those things can be used and under what circumstances those things can be used. Another example is we have governmental authorities relaxing licensure restrictions to make it easier for healthcare personnel to enter the workforce or travel between locations to help manage some of these patients. Another thing we're doing is increasing manufacturing. So I think recently I just read that we have Hanes, we have Fruit of the Loom, and some other companies that are coming together to increase the production of medical masks. So they're retooling their factories to produce medical supplies. And I think they estimated that they'd be able to produce for Central America and North America about 10 million masks a week. We have other instances like car companies that are working to produce ventilators now. We have people sewing masks and other healthcare equipment is being donated, et cetera, to try to get this back into the medical community. And there's also this, there's also some laws in place that may allow the president to potentially redeploy the workforce towards making some of these things. That's another thing we're doing to try to raise this capacity of the healthcare system. So with that, I'd like to turn things over to my colleague, Dr. Peters, who's really going to cover how healthcare systems are trying to raise the bar.
Right. Thank you, Zach. I appreciate it. I am David Peters, assistant professor of pharmacy practice and a critical care specialist, something that I work in, something that we're seeing on the front line, and want to talk a little bit about the strain on the healthcare system and then how we are going to help navigate some of these pieces. Zach, can we move to the next slide? Thanks. So when we think through the pieces, I'm going to talk about testing and triage, the personal protective equipment, medical equipment that's impacted like ventilators and intensive care unit beds, and medical personnel on a very specific format so that we can talk about what the risks are and what we're going to do to try to mitigate those risks. So let's start with testing and triage. So first, testing was a big buzzword about a week to 2 weeks ago because simply there wasn't enough tests available to try to contain the virus. Now that has been improved through local, state, and national departments of health, as well as collaboration with private industry. One of the things that we have seen in the past few days is multiple COVID-19 testing kits become available and become FDA approved under a very rapid approval by the FDA. Some of these tests are able to turn around COVID-19 screenings within 30 minutes or less. And it's been exciting to see some of that get released, but you have to remember that when these get released, that it's going to take time. Once they get approval from the FDA, it takes time for the manufacturer to ramp up the amount of tests available for the number of patients. And that's a high volume of patients who are coming in with fever and flu-like symptoms that are at risk for COVID-19. Now that said, as we've discussed, with an increased ability to test, we will see more positive confirmed cases. And so our spike of confirmed cases may go up much higher in the next few days as the expanded access continues. This is great on the healthcare system, though, because Previously, we may have been waiting 3 or 4 days for COVID testing results to come back. And patients who were negative but still had symptoms that were concerning might have been consuming resources like isolation rooms or personal protective equipment that were very burdensome on the healthcare system. So increasing testing and the rapid testing will very much improve and streamline our ability to care for patients and to rule out negative cases so that those patients can be cared for elsewhere or at other units of the hospital. Now, when you think about triage, this has been a really interesting development. Our emergency departments and really healthcare systems as a whole have prepared for national emergencies, and they've been ready over time to deal with whatever we could get into any situations, whether that would be man-made threats or a biologic threat like this virus. And so we're enacting some of the protocols that we've had in place. We just didn't know exactly what it would look like. It's interesting to see triage centers at different hospitals. Most of them are being triaged with a tent outside of the ED, something like a party tent that is helping to navigate patients who have symptoms related to COVID-19 to try to keep them away from other patients in the emergency department, to try to keep them triaged into a very specific area where workers are using appropriate personal protective equipment to try to protect our healthcare providers. These patients are then kept in very specific units of the hospital. I'm aware of multiple different health systems where they have very clear places in the healthcare system, in the unit, where they have patients segregated away from other patients, maybe even on their own floor. In most cases, patients who have mild symptoms, who are younger and do not have comorbidity and risks, are able to self-monitor and are able to self-quarantine. And so by rapidly testing them in these triage centers, if the patient doesn't have risk factors that require admission to the hospital, we can spare those hospital beds by sending the patient home with very specific monitoring parameters, very specific counseling points of what they can be watching for if they are developing severe disease, so that they can simply care for themselves. Because at the end of the day, most patients are going to have a mild illness. And if they cannot transmit to others, they'll be okay through this viral infection. The big buzzword now is personal protective equipment, and a lot of what we're talking about here are masks and gowns. These types of things protect healthcare providers in close proximity with those who are infected with the virus, and they help to make sure that we don't spread transmission from healthcare worker to healthcare worker, or healthcare worker to family, or patient to patient. There's a number of reasons of why we're strained on personal protective equipment right now. One of the big reasons is that we have an increased demand by the healthcare system and by the public. We did have some supply chain disruption from overseas manufacturing, particularly factories out of China that we were reliant on for some masks. That is tending to clear up at this time, but there's still inconsistent supply chain manufacturing. One of the big concerns right now is that providers may be at risk from an aerosol infection. And aerosol infections do require that N95 mask that has specific enough or small enough pores that it does not allow major particles through that could infect a healthcare worker in a room. It's likely that patients who are COVID positive in a small cramped quarters that have healthcare providers coming in and out of that room could potentially transmit through some kind of aerosol. And it is for that reason that N95 masks are absolutely vital in the care of these patients right now. There's some concerns of hoarding by the public even, and I've even seen some movements for those that maybe are lay people who have a large store of masks that have an ability to maybe email or reach out to health systems and even provide some masks back to the system to try to help bear some of the burden of this disease. With that, one of the most striking things that I have seen, I saw an article on CNN where a president of a health system, I believe in Georgia, said that they went through 5 or 6 months worth of supplies in less than a week. Very shocking. Some of that can probably be diverted by the healthcare systems by very strict use of PPE, but right now we're seeing an unprecedented time of the use of PPE. The CDC has even produced guidelines on crisis availability of masks You can see here strategies for optimizing the supply of N95 respirators, crisis or alternative strategies, and trying to outline what might extend out the ability of the healthcare system to manage some of this. It's interesting some of the provisions that they're making, including limited use and extended duration of these masks, where some healthcare providers may be required to try to wear the same mask for an entire shift, so long as it doesn't become overly soiled or difficult to breathe through. And it's trying to extend that out that will allow the most use and protection of our healthcare system to continue to raise the bar. When we think about the next big key piece, it's going to be healthcare equipment. When we think about critical care at this moment, a lot of the critical care needs for patients with COVID infection do require these patients with very severe disease may require a ventilator in order to breathe appropriately. Right now, it's estimated there's 160,000 ventilators in the field, but there's a caveat to that because really that's every ventilator available right now. Frankly, not all of those ventilators are very modern. Some of them may be being repurposed, and so we have limited ventilator resources. That said, there's about 12,000 ventilators available in the Strategic National Stockpile, which the president did mobilize. I believe several thousand of those are on their way to New York right now. We've seen increased ventilator production, so companies like Ford repurposing their factories to increase the production of ventilators to try to improve the outcomes of patients that need this. One of the interesting things about this particular case and in this particular virus is if you have a younger patient without significant comorbidities that does develop severe respiratory failure, if you can put them on a ventilator and get them through this particular infection, they may have great prognosis afterwards, but the ventilator is vital to seeing them through to that recovery. There's some many other things that we're doing to try to preserve healthcare equipment. One of the interesting ones, and one that's maybe impacting even some of our viewers, might be that elective surgeries really are on pause throughout the nation. And that could be to the loss of many people out there who were looking forward to an elective surgery to correct any kind of medical issue. But right now, those ventilators and those hospital beds are vital for the surge of patients that we expect to see. We're already seeing in New York some units that are very full of patients who are all COVID positive, and trying to manage some of these patients can be challenging if we do not have the right resources. You think about intensive care beds, we do need a place to keep these patients. The good news is that according to the Society of Critical Care Medicine, we in the United States have the largest number of critical care beds per capita. And that is encouraging. We have been preparing for this in the United States. We have excellent healthcare resources available. But that really amounts to about 100,000 intensive care beds at any given time. And those are not all available for a COVID positive patient, depending on the way the hospital is set up and the needs of the health system. While the US may have a significant amount of beds available, the rest of the health emergencies in this country don't pause because we have a virus available right now or in the country. And so we're trying to manage what would be a normal intensive care unit load on top of increased respiratory failure and patients coming into our intensive care units. One thing that was done in China was actually temporary hospital constructions, where they'd actually build small makeshift hospitals to try to manage some of these patients as best as they could in a safe and secure way. We have not implemented that at this point, but if you run out of beds, that can become something that needs to be done in order to navigate and raising the bar and trying to make space for these patients. There's also negative pressure areas. I talked about isolating patients with COVID-19. One of the things that is highly effective is making sure they're in what we call a negative pressure room. And what that means is that air particles can't escape out into the hallway. Again, if there is any theoretical risk that COVID is transmitted through air particles, we want to make sure that those stay within the room with the patient, and that our healthcare providers that go in have the proper masks to protect them in case of issues. The last thing that I want to talk about as far as raising the bar is our healthcare personnel. Frankly, they're a very valuable resource right now, no matter what job any of healthcare personnel have. When you look at the Chinese data, about 3.8% of the confirmed cases were healthcare professionals. And there was actually a very high probability of severe disease in healthcare professionals compared to the public. it's very important that we care for those who care for others, because we lose the ability to navigate and to provide appropriate care for COVID-19 patients if we lose a significant amount of our healthcare team. There's a number of ways that I've heard of healthcare systems dealing with these issues, including staggered shifts, temperature checks. I know some hospitals even checking employees' temperatures right when they come in the door, so that the rest of the workforce is not necessarily exposed to anything that could potentially mimic COVID-19. And then we always try to influence good hand hygiene across healthcare systems in order to decrease transmission of germs. This is all leading to very tough decisions, and we've seen this very strongly out of Italy, where healthcare leaders are having to make tough decisions, and it leads to all of these different variables in terms of navigating uncertainty. It's not that we don't have good data. We have new data coming out every day, and so really it's more that we have evolving data. It's the papers that come out change the way that we view this. The new models that we can make day by day with certainties of what happened yesterday are helping us to extrapolate out what's going to happen in the future with COVID-19. But there's a number of questions, including what is an appropriate staff to patient ratio, especially if staff become scarce due to staff illness themselves. We have medical treatments that are exciting, but maybe not yet fully tested. And so as we see different data come out, that's interesting to me as a pharmacist, thinking about what can we do from a pharmacologic standpoint to try to decrease the impact of infection and raise the bar by maybe shortening the length of infection. But we need to see good clinical trials. The last I checked, there was more than 130 clinical trials registered for COVID-19 in our national US registry, which is just shocking. We can also think about how non-physician healthcare personnel can be extended, including pharmacists, nurse practitioners, and nurses. One of the big ones with ventilators is our respiratory therapists, who are absolutely vital in managing ventilators, but are a limited resource if they continue to get sick. And then we've got to think about how visitors should be handled, which can be incredibly emotionally challenging to the healthcare system. Right now, most places do have a very strict limit or restriction. And it is very sad. You think about patients going into intensive care, the fact that they do have to be limited to maybe one visitor, but frankly, it's what's safest for the patient, it's what's safest for the family, and it's what's safest for the healthcare teams in this particular instance, though it is a difficult decision to make. So there's vast impact here of COVID-19, but we want to reiterate that we want facts, and we're going to continue to get facts. Over the next few weeks and months, we will understand more about this than we've ever understood before, and that will help us to make logical decisions moving forward. Fear will not help us in this particular scenario. We want awareness and not anxiousness, so that we're considerate of what we're doing, that as we think about social distancing and flattening the curve, that we recognize that these are positive steps in decreasing the burden of infection. And we want preparedness and not panic. We know that we can have positive outcomes with this, but we've got to navigate it as a society and work together, especially within healthcare teams.
So thank you, Dr. Peters. That was very helpful. So with that, we'd actually like to open things up to questions from you, and we'll do our best to try to address them as a team.
All right, so it looks like we've had a high volume of questions regarding how long can COVID-19 live on surfaces. There's some people saying it could be up to weeks. There's some saying it could be on days. The question specifically from Mark out of Dayton was, what does the evidence show about how long COVID-19 can really live on surfaces, and how is it transmitted? And that's a great question. And we're still learning some of the key pieces about it. There was one relatively robust paper that was published recently that looked at multiple different surfaces for how long the virus could truly survive, this COVID virus that we're dealing with in COVID-19. Some of the key findings, they found that on plastics, COVID could live up to 3 days. So maybe not necessarily the week that we were worried about, or even up to 20 days, I heard from some sources, but it does last for quite some time. On plastic, 3 days. I heard cardboard was about 24 hours, stainless steel about 2 days. It really highlights that we need to be decontaminating surfaces, especially as you come into contact with others. So using Clorox wipes or alcohol-based hand sanitizers that are greater than 60% so that we can wipe off those surfaces. I think about my phone personally, how often my phone is in my hand, and sometimes I set it down on different surfaces. If I am out, which hopefully we're limiting that right now, but my phone should be decontaminated so that I do not pick up virus from there. And then you finish your question with how's it transmitted. Right now, it is definitely transmitted person to person through droplets. So through virus droplets that come out through our coughs, usually end up on our hands or on our sleeves. We can then, if we shook hands, we could distribute to somebody else's hand who can then, when we touch our face, can actually become infected in that way. As healthcare providers, we're worried about aerosol transmission. I don't know that in the public aerosol transmission will be highly worrisome, because that's mostly worrisome when you're in a small hospital room with a patient creating a lot of secretions, coughing a lot, sneezing a lot, and having maybe less thorough air circulation. So that is possible, though the data is still coming out on whether or not that is a high likelihood for infection.
And I guess I'll add to what Dr. Peters just shared there. So the study that they actually were looking at when it did talk about aerosolization and saying that maybe a particle could live in the air for about 3 hours, they actually created an artificial environment that ended up making things aerosolize, which we don't really have if you're thinking about just walking out on the streets. So that is one real weakness to that data. And as Dr. Peters really emphasized, we know it's mostly through droplets. So that's why we're trying to save those really important masks like the N95s for our healthcare providers, because as Dr. Peters illustrated, really the ones who are at the bedside where maybe there's that slight risk, if it's there, are probably more likely to encounter it in that setting. I did get a really interesting question that was sent to me directly here. So basically, the question was, when I showed that diagram earlier of the peaks where we were talking about delaying things through social distancing, you saw that eventually there still was a peak. So the question was really, are we just delaying the inevitable? Because again, this is without pharmaceutical interventions. And so in a way, yes. So we will see it peak at some point. But I want to also point out, and these slides will be posted for everyone later. In this video, you can go back and look at this too. But the peak itself is lower than if we did nothing. So we could still exceed capacity. But the other thing to add, the time lag between now and then changes pretty dramatically. So that gives our healthcare system time to increase our capacity, which then makes it easier to not necessarily be overwhelmed. So that's the value of some of this social distancing right now. So then another question, Dr. Peters, I don't know if you want to weigh in on this. Can masks be sanitized to allow healthcare providers to use their masks for an extended period of time?
Yeah, I saw that. I thought that was a very interesting question, and very timely. That CDC link about crisis management of N95 masks actually does slightly address this. And the answer is yes, masks can be sanitized, but it really is a last case resort. It's not something that we want to routinely be doing, because frankly, we don't have good data that suggests that if you sanitize a mask, that you're going to be able to use that mask as effectively as a mask that has not been maybe altered or tampered with, like we could say maybe bleaching a mask would do. So it's possible, but frankly, it's really a last case resort, in my opinion, and based on the CDC data for what would happen if we were in a severe N95 shortage. One of the positive things that I think I've seen from maybe the cooperation of private industry along with the public health initiatives is a production and a repurposing of N95 masks. So construction companies actually use a significant amount of N95s while they work with any particleized maybe construction. And we've seen huge waves of construction companies actually reaching out to health systems and saying, can we help? Can we distribute back masks to you guys right now so that you can hold on to these and potentially do your job in a safe way. It's been exciting to see. It's been encouraging to see. We just got a call the other day from a company that offered one of the health systems that I work with a significant number of masks, and it's been a great relief. It really is a positive, encouraging note for us.
Yeah, and there's another study I just saw that talked about, can you take a mask and sterilize it by sticking it in an oven and cranking up the temperature. So that's an interesting thing right now. So there's also discussion in the community about people making masks. So if you went to Joann Fabrics, for example, you actually can't get elastic now because people have been buying that to try to make masks. So sticking it in an oven, you end up not having elastic to make the mask because the elastic ends up burning off, is what they found. So they are looking at lots of ways, as Dr. Peters pointed out, to try to sterilize those masks and see if we can reuse things if at all possible. So this is another really good question here. So I heard that the symptoms and ages have shifted. Does this mean it has mutated? So that's an interesting thing. So part of this is, and I think Dr. Peters brought this up earlier, it's shifted, but I think the consideration is we don't necessarily have all the variables right now. One of the limitations of the Chinese data, which is where a lot of this is centered around, and it was 50-some thousand patients that they ended up reporting out, the majority that were tested were actually serious cases. It's not representative of the people that were out in the community. So unlike South Korea, where they tested a large volume of people, they didn't necessarily do that in China. So the symptoms that were initially reported, the ages that were originally reported, are pretty representative, but may not be completely representative. So this is, again, a case where we're learning more and more. And to that, there's another question that I think I'll tie in here. So the GI symptoms now appear to be something to be watched for. Did you see this kind of come out in the literature, Dr. Peters?
Yeah, I know that the GI symptoms have become more prominent over time. And I think the last I saw, potentially up to 48% of patients have had GI symptoms out of one study out of China. And in 7% of those, that was their only presenting symptoms. I've heard, secondhand stories of people that just had GI symptoms. They didn't really have significant respiratory symptoms, though many of them would develop a cough. I think over time, we'll see that GI is actually probably more prominent than we thought.
Yeah, and that's definitely an interesting discussion that we have to kind of keep aware of, because it does make it really hard as we're dealing with all these respiratory viruses to figure out which one it actually is with the patient, especially when we're waiting on those test results to come back. So that's a real challenge for healthcare providers right now. So there's a question here.
If I might cut in, I might add to the worry about changing ages. I would probably caution those that are younger that we're not going to be vulnerable, or we're not going to be invulnerable to this. You're hearing stories left and right about patients who are younger ending up in the ICU on ventilators, patients who are younger that are contracting the disease. And I don't mean to spread panic. We want to be prepared, not panicked. But I think those that are younger that do not take this seriously, and particularly don't take social distancing seriously, need to highly consider that this, while unlikely to be more severe in a young patient with lack of comorbidities, can still become severe and can still become even severe enough to go to the hospital.
Yeah, that's a great point, Dr. Peters. And the CDC is trying to analyze all this data as it's rolling in, as tests are being done, and it takes time. But I know that they looked at about 2,500 cases or so, and they ended up saying that about 38% of them ended up being under the age of 60, or I think 58. And about 40% were essentially under the age of 40. So as you said, definitely some of our younger population aren't invulnerable. They aren't necessarily the ones that we see some of the fatality with, but this is something that's continuing to evolve. A good example, so there was actually a group here. This is kind of sad, but there was a local group of high schoolers that had a party, and they had about 60 people after some of these social initiatives have been done. And they met as a big group. One person was there that had been in France on spring break, and they ended up testing positive for COVID-19. And so that family now had to inform all of the families of all of those high schoolers, hey, you may actually have someone that was potentially exposed to that. So social distancing, as you said, is a big thing to employ here. So there's a question here. How long do you think this will last, and what about the lockdown? So This is actually coming out of London, Ohio. So I think we could probably speak to some of the things that are going on in Ohio itself. So I guess what's your feeling right now and how long you think it might last?
Sorry, I had to fix my my background. I was starting to blend in based on how the lighting was changed. I think that if we follow the trends of some other countries that have truly locked down with social distancing, then you can see a peak about 4 to 5 weeks in of the extended infection that are growing across. But then also you do see a plateau. There can be a light at the end of the tunnel if the strict measures are held for now. We don't know if there will be recurrence of infection, especially as people get back into society. But South Korea and China have seen a little bit of a leveling off. The cases in Italy that are not growing anymore, and that's encouraging, at least for us to see right now, since we're about 10 to 15 days behind Italy. But like you said, we have so many more focuses of infection in the United States. It's going to be difficult to predict. It's going to be a week by week determination, and it's going to be something that we'll have to continue to evolve with the data to try to figure out what the right measures are. Optimistically, could we be back into a normal routine by Easter? It's possible. It's possible that these measures help to navigate and to quell some of the concern. But realistically, we have to keep in mind the fact that if we do have exponential growth that is not curtailed over a few weeks, like we might anticipate based out of China or South Korea, that we could be looking at a little bit longer duration of isolation.
Yeah, and I would definitely agree. And I'll speak strictly from a professional opinion and not necessarily one based purely in science when I say this. So my guess is, if I'm just going with my gut feeling, I think they're probably looking at things every week or 2 weeks and making big decisions like whether things will continue based on some of those interim analyses. I think that's kind of going to be what's the normal moving forward for individual states and certainly for the federal government. Because again, this data is pouring in, they're doing their best to analyze it in real time, which is really, really difficult. So one big question is, why does it look like it'll be over faster if we do nothing?
So ultimately, it would be over faster if we did nothing because the amount of cases would be increased greatly, but the capacity would overwhelm our health system just remarkably. It would be an incredible tragedy to have a peak that high and to overwhelm the ICU beds and the amount of ventilators. You think if we expect to have a certain number of coronavirus cases in the United States, which we do, somewhere around, conservative estimates, potentially at 50%, maybe less than that of people who get infected. If all of those people get infected over the next few weeks, then we are looking at a surge of need of ventilators that we simply don't have the capacity to provide a ventilator. And people would die that would otherwise not die if we were able to spread out that particular infection over a series of time. And that's the key. If we can flatten the curve while we mobilize more healthcare resources, because that's what we're also trying to do. We're trying to buy time for the healthcare system to provide appropriate care for our patients and the most appropriate care. If we can buy that time, then we can manage more of these infections in the most optimal way. It's likely that at the peak of this, we're going to be stressed from a healthcare resources standpoint. We want to stress that as little as possible to provide the best care we can.
Absolutely. And even in that study that was done by the Imperial College of London, they end up stating that the mortality is definitely higher when you let it all peak at once. So more people, as Dr. Peters said, are potentially going to die in a case like this, even though it would end things earlier. That's actually that ethical question you really have to weigh. How much is a life worth? And that's a really tough thing as healthcare providers that I think we all kind of struggle with.
Yeah, we have enough difficult questions to answer already. Adding in the ethical question of how to navigate if there's if you're on your last ventilator and who gets it, that becomes a remarkably difficult and emotionally damaging decision for the healthcare team.
Absolutely. So it seems like a pretty popular question. So they say that, let's see, we would like to sew masks. Is it wise? If N95 masks are really the best, should I be contributing homemade fabric masks? If so, which fabric is best for healthcare workers? Do you have any thoughts on this, Dr. Peters?
It is a great question.
Yes.
Frankly, as far as the fabrics are concerned, I don't know that I have any expertise right there. Right now, the mobilization of masks from the public are generally, I've seen mostly through email to different healthcare systems. They're setting up emails for COVID response. And so I'm not positive the ones in Dayton right now, if they have that readily available. Or otherwise around the country. I've seen multiple through Twitter where they're reaching out to the public. So you could look and search to see if your local hospital has maybe a COVID hotline or a COVID email hotline, and then ask them maybe what they're looking for that they need in terms of medical supplies. We would love anything that the public can contribute. Large
Mhm.
or small donations right now will certainly help to manage some of these infections. Ultimately, this is really a team dynamic. And in the United States, we have just some incredible people that are willing to contribute and step up. We've talked about that in private industry. We've talked about that in our public. And those that want to contribute, I would say the best way is to reach out to some of these health systems through their COVID hotlines or through the portals that they're creating, many of them on their websites, probably directing some of that traffic.
And I guess I'll add to that just a little bit here. So, um, as far as fabric goes, if you compare an N95 mask to I guess like a surgical mask, which is the typical mask you think of, on the N95s, what's unique about them is they're specially fitted to people. They actually have to have a fit test to make sure that it's more or less tight enough so particles can't get through. Um, and so the challenge there is it's very hard to create something like that at home that necessarily would be applicable in that setting. Another challenge with the fabric used in the N95 masks is the pores, basically the holes that allow moisture and breathing, et cetera, through. They are about 3 microns in size, which is really, really small compared to typical fabric that you could find. And so it's hard to necessarily create something of that same caliber. But as we've kind of talked, the primary means of transmission is respiratory droplets, the big droplets, as opposed to the little particles. So a mask in general could be an added benefit, but the answer, as Dr. Peters kind of alluded to, it really depends on what the healthcare system is willing to accept. And that's largely probably going to be influenced by what their immediate needs are. I've read of some cases even where people have sewn covers that could be worn over an N95 mask so they don't have to be changed as often. So there's lots of things out there along those lines. So there's another question here. If I have 2 N95 masks at home, will the small number of masks be helpful, or should I keep them in case my family would need them? That's a
Yeah,
tough
I think
question. That's a good question, though.
Yeah, it's a great question. Ultimately, N95 masks are useful for home construction projects. They're useful for some people in terms of their own day-to-day life of what they need. If you've got 2 masks at home and you want to hold on to them because you have 2 people at home, that could be reasonable at this time. We're mostly concerned, and maybe with the public, those that have 3 boxes of N95 masks right now that might
Yeah.
be able to contribute, something like that back. I don't think it's unwise to hold on to an N95 mask. Again, some things around the house will be very useful to have an N95, but you don't need 50 right this moment. And our healthcare team might actually benefit from that and really in a great way. So that would be my advice at that point.
Yeah, it's really a personal choice. You have to think about according to what we know, the people that will most likely benefit from masks are those on the front lines or those who are sick, so they don't spread it to other people. So if you happen to have someone that is sick, they have COVID-19, and you're concerned that they may spread it to other members of your family or people they're around, that's where there's some value in actually having the masks on hand. So it's really a personal decision, but you have to think about what's the likelihood that you'll end up having that sick family member or someone that you know versus actually the person that's on the front line with that every day. So I won't necessarily say do one thing or another because I really think that's kind of up to you as an individual.
Yeah, I did get an interesting question that I can answer quickly. I got a question that said, "Do we have any false positives?" Um, and it's a great question. I think it's something that we do absolutely have false positives. Every test that you have in medicine will have false positives and false negatives. The good news in this case, I think, is that a false negative would be more damaging than a false positive. To tell someone
Mhm.
that they didn't have COVID-19 and then potentially have them go spread their infection would be very damaging. But What's going to be unique over the next few weeks and months is that all of these laboratories that are developing their own COVID-19 test will have different rates of false positive and false negative. It depends on what type of test they run. So we have multiple kinds that we can run. We have polymerase chain reaction type test, or PCR, which look for DNA that tend to be relatively specific to infection. We have what we call an ELISA test, which is based off of antibodies that tend to be less specific, and they have more false positives associated with that testing. So widespread use of the ELISA type testing, which tends to be quicker and cheaper, would lead to more false positives, would actually lead to a higher case rate, and maybe even more burden on the healthcare system. So as we get more tests, it will depend on the cost, but potentially shifting and using more of the PCR-based testing may be beneficial to try to decrease that false positive rate and be more sensitive to identifying which patients truly do have COVID-19.
Yeah, and based on at least what I've read, most of the testing that's really specific for COVID-19, it tends to be pretty accurate at identifying it, and saying that this is absolutely, since I detected something, this is absolutely the thing I detected. But, as Dr. Peters pointed out, sometimes it doesn't have the ability to detect it. There are false negatives. And I think the rate is about 20 to 30%, but those things are improving. And so sometimes, depending on what you look like, you may get tested more than once by a medical provider during that same encounter. So this is something that's evolving. If you kind of compare it to the previous SARS outbreak, there are actually lots of false positives, not so much the false negatives. And so that actually caused quite a bit of a scare. So it kind of goes both ways. And the ideal situation, you want the most sensitive and most specific test. And involving, I think, the third parties out there, that's actually led to an expedited improvement in the quality of tests that are currently available. So there's a question here. What's being done to increase bed capacity, since it looks like we're headed that way?
Yeah, so I can tell you just from being around different workers in healthcare, as well as seeing many listservs, like email chains of healthcare providers around the nation, and talking with several different pharmacists from across the nation, that we're trying to limit census as much as possible. And what that means is we are trying to get people safely out of the hospital very quickly. So there's been some interesting movements on this regard, where maybe we're canceling the elective surgeries so those patients don't take up hospital beds. We are actually able to maybe move patients to rehab facilities a little bit quicker than we were previously, by eliminating what we call the 3 midnight rule, where people had to stay for a certain amount of days just to make sure that they were stable. Patients that are truly stable and are ready for discharge, we're able to get them out to a rehab facility more quickly. Then again, you've got the idea of maybe making some makeshift hospitals, but I don't believe we are there yet. And that truly becomes a crisis mode type of makeshift fix. I've seen some interesting things online talking about repurposing repurposing hotel beds as rehab. I've seen that. I've not heard that actually has happened in the United States.
So actually, on that note, I think in New York, they've just started talking to some motels to try to convert those around. And I think Governor Cuomo also just announced that they're going to try to build some hospitals in light of what's going on over there.
Right. So thank you for that insight too. I think those things are key pieces of increasing hospital beds, and then again trying to limit other non-needed uses of hospital beds is for us the most important, because we have a lot of hospital beds in this country. It's, can we utilize them most appropriately right now, and can we utilize them when we have surges of patients? And so I know even lots of places who have doubled up. You've got the ability to maybe put 2 beds in one room. We do that if there's no infection risk, of course.
Yeah, and just to give you a practical example of how those measures that Dr. Peters have kind of shared have played out locally in Ohio. Originally, according to the Ohio Hospital Association, in Ohio, we were about at 75% bed capacity, which is pretty normal for this time of year where we have all the respiratory illnesses, et cetera. But since we've done a lot of these initiatives, like putting those elective surgeries on pause, et cetera, we've actually bumped that capacity up. So we went from 75% total capacity down to 60% capacity, meaning we have about a 40% capacity of beds still available. So we've improved what was available, and that's just what's been done so far. That's a really good question. So this is another good one. So we talk about, in that previous slide where we had some of those peaks that showed summer and fall, and again, that was based on non-pharmacologic interventions. What pharmacological interventions can we expect to see between now and potentially if things ramp up by the fall?
Yeah, there are multiple clinical trials in place right now, and it is exciting. I think two of the most exciting treatments, the first and probably the most popular, thanks to Twitter, is hydroxychloroquine and azithromycin in combination. There was a study out of France that had a small number of patients, but they had remarkable results. And there is truly some pharmacologic benefit of hydroxychloroquine based on its mechanism of action to halt some of the viral shedding and halt some of the viral spread. That could potentially decrease severity and duration of disease. Azithromycin has some theoretical in vitro ability to combat the virus, though maybe a little less well clarified than hydroxychloroquine itself. And I think the big key for us with that treatment is to let the process play out as it should. We have clinical trials in place so that we can protect the public from unnecessarily adding medications. And so we really want to see this compared against placebo in a well-run study that gives us some certainty of whether or not there's a benefit here. I think that's super key. And then to move on to maybe the next most exciting, probably, or I don't know which one's more exciting, but remdesivir is an antiviral medication that was previously unavailable, but has been made available in the United States through both clinical trials and what we called compassionate and extended use. So we're being able to utilize this as a treatment in most of the viral illnesses. Again, making sure that we study it out, that we understand when we're adding pharmacotherapy to patients, that we are getting a benefit of adding the pharmacotherapy without an increased risk of side effects, which come hand in hand with all medications. I think that's important to keep in mind, and maybe not necessarily jump to a solution in healthcare. We love to add meds so that we feel better about what we're treating, but we want to make sure that what we're adding isn't going to cause any more harm than what we have on hand. So I would be looking out for those two. There's been other things that have been studied. There's a drug for rheumatoid arthritis for very, very severe illness called tocilizumab that has been utilized on a number of fronts for patients who have maybe severe end organ damage as what we might call a salvage therapy when we're really trying to extend out all resources that we have to save somebody's life.
Yeah, I mean, there's definitely a lot in development or potentially available. I think I read something the other day that suggested that there are about 47 different compounds that are being looked at right now to help try to address this. But, as Dr. Peters just stated, one of the big challenges that we run into is first off, we have to make sure the drug is appropriate for the patient and that it's effective. But then the other thing we have to think about is what does that do to our supply chain? And practically how this has worked out. So there was that study that came out that Dr. Peters referred to in France that looked at a combination of hydroxychloroquine and azithromycin and showed maybe some preliminary data that could be helpful. And so many people jumped on that immediately after it actually was published that not only could we already not have an easy time getting a hold of a hydroxychloroquine, the other drug, azithromycin, also went on national shortage. So the big problem, if we take a step back from just COVID-19, we have other patients out there who actually need those drugs for other conditions. So azithromycin as an antibiotic is used for certain things. And then hydroxychloroquine is actually used for people with things like rheumatoid arthritis or lupus. And so potentially it puts those patients at risk if we can't get those patients the drugs they need. And that's why a lot of these regulations have been kind of put in place, as I spoke about earlier, to try to limit how often some of those things ended up getting used. And I guess one last question we'll take here. So are UV filters effective?
I got to say, Zach, I don't know that I have any expertise there. Do you have any insight?
Based on the little I've read, I think it's hit or miss. I've read some things that said they are and some things that said that they aren't. And this sort of ties back to the question of whether or not we know heat or UV light ends up killing the virus enough. And could this actually disappear by the summer? That's the hope that it could. There's some early studies that suggest that maybe that's the case. But right now, the data is pretty weak on that front. So at least that's my understanding of where we're at with the research to date. But I guess we'll end on that. So what we'd like to say is thank you all for joining us today. We appreciate your questions. And Dr. Peters, I really appreciate you joining us today and really sharing your perspective about what it's been like in the ICU setting with managing some of these patients.
Yeah, thank you for having me. I appreciate it. And we'll continue to gain more certainty as we reevaluate data. I know that we'll be using this data for really a long time in terms of how we navigate infectious disease crises and emergencies. And really, hopefully, when we come out on the other side, we get a lot of certainty with what to do and how to try to treat these viral illnesses.
So with that, I'd just like to say thank you again for joining us. Stay tuned. We'll have more town halls coming in future weeks discussing a variety of different topics.